You wake up every morning with a jaw so tight it aches. Your teeth are sensitive, your neck is stiff, and you've been diagnosed with TMJ. You wear a plastic night guard, but the pain never stops. What if your jaw clenching isn't a dental problem at all? What if it is your brain's desperate survival mechanism to keep you from suffocating in your sleep? Today, we expose the airway secret. This video is for educational purposes only. Jaw pain, especially if it radiates to the neck, arm, or is accompanied by chest tightness, can be an atypical symptom of a heart attack, particularly in women. Seek emergency medical attention if you suspect cardiac issues. Never ignore acute, severe joint pain. First, let us validate the experience. TMJ pain is not imaginary. Temporomandibular disorders are a real family of conditions that can cause pain in the jaw joint, the chewing muscles, the face, and even the neck. Morning headaches, jaw stiffness, limited opening, clicking, and tooth sensitivity are all symptoms people live with every day. If you have been told, it is just stress, that answer may feel insulting because it often is. Your nervous system is not making this up. Now let us dismantle the night guard myth. A standard splint can help protect teeth from wear and absorb force, but it does not automatically stop the clenching signal that created the force in the first place. In TMD, evidence for splints reducing pain is mixed, and often low quality, which is why so many people feel trapped. The appliance protects the teeth, but the pain keeps showing up in the muscles and joint. That is the difference between buffering the damage and solving the driver. Here is the airway piece that most people never hear. Obstructive sleep apnea is a disorder of repeated upper airway collapse during sleep, and UARS sits nearby on the same spectrum, where airflow resistance rises and sleep becomes fragmented even when oxygen drops are subtle. When you lie down, gravity can encourage the tongue and soft palate to fall backward, narrowing the airway. Your brain notices that narrowing is danger. And that is when the body gets strategic. Sleep bruxism frequently co-occurs with obstructive sleep apnea, and many events are time-related to arousals from sleep. In plain language, the jaw can become part of the rescue system. The brain may recruit the jaw muscles in an attempt to restore airflow and protect oxygen delivery. So when someone says, "You just grind your teeth," that explanation is often too small. For many patients, the story is not teeth first. It is breathing first. It is an airway problem wearing a dental mask. Now let us connect the symptom to the system. Obstructive sleep apnea happens when the upper airway becomes repeatedly blocked during sleep, reducing or stopping airflow. Upper airway resistance syndrome, or UARS, sits on the same spectrum of sleep-disordered breathing. The airway may not fully collapse, but resistance rises enough to fragment sleep and keep the body on high alert. In both cases, the problem is not just bad sleep. It is a breathing problem playing out through the night. Picture what happens when you fall asleep on your back. Gravity does what gravity does. The tongue and soft tissues can drift backward, and in a narrow airway that is enough to create resistance or collapse. If you already have a high arched or narrow palate, poor tongue posture, nasal obstruction, or other anatomic crowding, the airway has less reserve. The result is not dramatic in the Hollywood sense. It is often quiet, repetitive, and invisible: snoring, micro-arousals, and constant sleep fragmentation. And when airflow is restricted, oxygen delivery can fall. That matters because the body is exquisitely sensitive to even small changes in breathing chemistry. In sleep apnea, intermittent hypoxemia and repeated breathing instability trigger arousal chemistry, sympathetic activation, and a stress response that is designed to keep you alive, not comfortable. This is why people often wake unrefreshed, with morning headaches, dry mouth, and a body that feels like it never truly stood down. This is where the jaw often enters the story. When the airway is compromised, the brain does not care about your dental terminology, it cares about ventilation. The nervous system can respond with increased muscle activity and repeated arousal-linked jaw activation. In sleep bruxism, studies show a common co-occurrence with obstructive sleep apnea, and many bruxism events are time-related to arousals rather than random habit behavior. So the clenching is not always a bad habit. In many patients, it is a rescue pattern. That is why the symptom pattern feels so cruel. You grind, you clench, you wake with facial pain. And then you are handed a guard that protects the teeth but does not fix the reason the brain is recruiting the jaw in the first place. The body is trying to stabilize breathing. The jaw is being conscripted into a nighttime emergency plan. So when we talk about TMJ pain, worn enamel, morning headaches, and relentless clenching, we must stop asking only, how do we cushion the bite? And start asking, why is the airway unstable during sleep? That single question changes everything. Because when the airway is restored, the jaw often stops having to fight for breath all night long. Here is the part that changes the entire conversation. Sleep bruxism is not just teeth grinding. In the scientific literature, it is defined as rhythmic masticatory muscle activity during sleep, and that activity can show up as clenching, grinding, bracing, or even mandible thrusting. In other words, the jaw is not simply misbehaving. It is moving with a pattern that the nervous system is generating during sleep. And in patients with obstructive sleep apnea, jaw-closing muscle activity often follows respiratory events. One study found that mandibular advancement appliance therapy reduced only the jaw-closing activity that occurred after apneas or hypopneas, especially when those events were tied to respiratory arousals. That tells us something important. In at least a subset of patients, the jaw response is not random. It is downstream of the breathing disturbance. This is why researchers have proposed that sleep bruxism may sometimes function as a reactive, even protective, mechanism against upper airway obstruction. The body is trying to solve a ventilation problem. The jaw becomes part of the rescue system because the airway is the problem the brain is trying to fix. That does not mean every case of bruxism comes from sleep apnea. The literature is more nuanced than that. Bruxism is multifactorial, and researchers caution against claiming a simple one-cause explanation for everyone. But it absolutely does mean we should stop treating every clenching patient as though the teeth are the whole story. So when a patient says, "I clench all night," the deeper question is not, how do we silence the jaw? The deeper question is, what is the airway asking the jaw to do? Because if the brain senses repeated airway resistance, repeated arousals, and unstable breathing, it may recruit the jaw again and again to keep the passage open. You are not fighting your body. Your body is trying to keep you alive. So what is the true solution? Not more guessing, not more random guards. The real target is airway stability. That means nasal breathing whenever possible, reducing upper airway resistance, and restoring the oral posture that lets the tongue and mandible support the airway instead of collapsing around it. In sleep-disordered breathing care, myofunctional therapy is used to retrain the oral and oropharyngeal muscles, improve tongue posture, and support nasal breathing as an adjunct to medical and dental treatment. This is why the right team matters. A sleep physician evaluates the breathing disorder. A qualified dentist trained in oral appliance therapy can fabricate a custom, titratable mandibular advancement device when appropriate, and that treatment should be coordinated with medical care and follow-up sleep testing. The best results come from a multidisciplinary plan, not from a one-size-fits-all splint handed out in isolation. And I need to say this clearly: never attempt to file, grind down, or even out your own teeth at home to fix your bite. This causes irreversible enamel damage. Always work with an airway-focused functional dentist or a myofunctional therapist. Home grinding does not solve the airway. It only creates new damage on top of an existing problem. So the message here is not, your jaw is broken. The message is that your system may be under-breathing at night, and your jaw has been trying to compensate. Once the airway is addressed, you can stop fighting the rescue mechanism and start treating the cause. That is the difference between endlessly managing symptoms and actually changing the trajectory. Once the airway is improving, the jaw still needs rehabilitation. Years of nocturnal clenching can leave the temporomandibular joint and surrounding tissues irritated, sensitized, and mechanically overloaded. In TMD, the problem is often not a single damaged structure. It is a pain and function system that has been under strain for too long. That is why recovery is not just about stopping symptoms. It is about helping the joint calm down, unload, and move normally again. Here is the biology that matters. TMJ synovial fluid is rich in hyaluronic acid, and in inflammatory TMJ conditions, the quality of that lubricant matters. Reviews of TMJ literature note that hyaluronic acid-based approaches have been studied because they are tied to lubrication, friction reduction, and symptom relief in some temporomandibular disorders. That does not mean every product is the same, and it does not mean every patient needs a supplement. It means the joint's lubrication environment is part of the conversation. So when people ask about a premium joint lubrication protocol, the idea is not magical repair. It is support. A hyaluronan-containing joint formula such as Joint Genesis is marketed as a joint support supplement with ingredients including hyaluronic acid, and the brand says it is designed to support lubrication, flexibility, and mobility. In other words, it is positioned as an inside-out support strategy. Not as a replacement for airway treatment, not as a substitute for a sleep evaluation, and not as a cure for TMJ. And I want to be precise here. The most responsible path is to pair airway treatment, jaw unloading, and professional guidance. TMD care should stay conservative whenever possible, and treatments that permanently change the teeth, jaw joints, or bite should be approached with extreme caution. This is also why anyone with pain that radiates beyond the jaw should be medically evaluated, not guessed at. So yes, fix the airway, calm the nervous system, and then help the TMJ recover its lubrication and function. That is how you stop treating the aftermath and start treating the mechanism. And remember, jaw pain that spreads to the neck, arm, or chest can be a medical emergency, especially when it comes with chest tightness or shortness of breath. Never ignore acute, severe pain.